So this is mild. All right. What will you do in mild? What will you do in mild? Can somebody tell me?
Salbutamol inhalation.
Okay. Number 1 is salbutamol inhalation. Number 2. How will you give it, and what is the, how many frequently can you give? And okay. So, if number 1 is the oxygen, if because the category is 92%, but you need to keep a saturation more than 94%. So, low flow nasal cannula or a face mask oxygen, if required, if the saturation is low, and salbutamol inhaler or nebulizer. Okay, so you will give about 2 to 10 puffs. You can give in one go. Okay, and then I will just tell you about what the discharge criteria is. You will reassess. So after 10 puffs, 2 to 10 puffs depending on how much the child requires, you will reassess after 15 to 30 minutes and repeat your management again. Okay, if there is no improvement. So this is for the treatment of the mild to moderate asthma. And if the child meets the discharge criteria after the oxygen and the Ventolin, the salbutamol nebulizer or inhaler technique, then reassess after 15 minutes. If the child improves, then you observe for 4 hours to see that there is no deterioration. And then if the child meets the discharge criteria, you can discharge the child on the home medications, which we will just discuss. Okay, so salbutamol inhaler, the meter dose inhaler, 2 to 10 puffs, or through can be given through spacer. Okay, then oxygen to meet the saturation, and what is the discharge medication? Once daily oral prednisolone. If maintenance therapy, discuss with a respiratory consultant. Age less than 2 years, you give 10 milligram, 2 to 5 years 20 milligram, and more than 5 years 30 milligram. You don't need to know the dose. Okay, so if you reassess after the 15 to 30 minutes, and if he needs the treatment, you repeat the treatment, and you discharge once he meets the discharge criteria. So what is the discharge criteria? One was that criteria to admit to manage as mild to moderate acute asthma exacerbation, and the one is the discharge criteria. So it's the same things but different parameters, but same parameters but different values. Okay, so for the discharge, the child has to have an oxygen saturation of how much? 94%. Okay. So this is what we mean by the vitals. Okay, so these are some important values actually. So you will categorize it to less than 5 years, 5 to 12 years, and 12 to 18 years. Okay, less than 5 years, 5 to 12 years, 12 to 18 years. So for less than 5 years, the respiratory rate should be 40, and then 30, and then 25. Just remember it like this. So 40, 30, 25, and 140, 125, and 110. So just these are, not very difficult values. So just remember these values. Okay, so 40, 30, 25, and 140, 125, and 110. Okay, so these are your vitals for discharge. Then the peak flow for the mild to moderate exacerbation, they were more than 50, but for discharge, they have to be at least more than 75%. Okay, and stable on 4-hourly inhaled treatment. So we have tried an 4-hourly inhaled treatment, and the child remains well between these two inhaler treatment, between the 4-hour episodes. So the child is fit to go home. Okay, so he meets these discharge criteria, we will discharge him as we discussed, 3 to 5 days of daily oral prednisolone and review. Okay, so what the other important things, I will also, I've expanded this in another slide for you, but let's go through it right here as well. Before sending the child home, you need to make sure that the control is well, the child is using proper technique. Okay, just give me a minute. Okay, sorry. You give the oral prednisolone 3 to 5 days short course. You check the inhaler technique. You make sure that the child has his own personal asthma action plan, which has been made for him, and you agree to a follow-up plan depending on when the child is fit to come, and complete respiratory discharge letter. Okay, so this is as for the management of mild to moderate asthma. Okay, so anybody has questions regarding this one, then we will move on to the severe and the life-threatening one. Okay, so depending on the parameters, the identification, then the management in the form of oxygen, salbutamol inhaler through either spacer or through the meter dose inhaler, and then reassess after every 15 to 30 minutes. If they meet the discharge criteria, we discharge home with oral prednisolone and with an asthma action plan, make sure their technique is okay, and with follow-up. Okay, so the next one is our severe severe asthma attack or severe asthma exacerbation. So number one, what was here? The vitals. So the vitals, they have to be the child was vitally stable here, but there was some distress and the oxygen saturation was a bit less, and the peak expiratory flow rate was also 50%, but less than 75%. Now here the child is too breathless to talk or feed. Okay, so there are signs of distress. Number one, the oxygen saturation is less than 92% even, and the vitals are disturbed. So how are they disturbed? As we discussed, 5 to 12, 12 to 18, so 40, 30, 25, and 140, 125, and 110. Okay, and the peak flow expiratory flow is less than 40%. Okay, for this is for less than more than 5 years of age. So what do we do here? What is the difference between giving the salbutamol here and between the mild to moderate and the severe one? What is the difference?
We should straight away start with the 10 puffs.
Mm-hmm.
With the oxygen, we have to start.
And with the oxygen.
Yes, the better way to do it is given nebulizer through the oxygen mask. Okay, so oxygen driven nebulizer, so the child can improve quickly. We're giving high flow oxygen through the face mask, and then the oxygen driven nebulizer. So number one is that. Okay, this so what is the second step? If no response immediately with the salbutamol inhaler through nebulizer or through immediately after giving the puffs. Yes, the second is ipratropium bromide. Okay, so first of all, beta agonist. The second is anticholinergic in the form of ipratropium bromide nebulizer. So it also has its dose. You have with the atom, you have 250 micrograms, and you have the 500 micrograms for less than 12 and more than 12. Okay. Then after that, the next step is the oral steroids. Okay, so the oral steroids in general, systemic steroids. So you will give oral steroids if the child can tolerate. If the child cannot tolerate the oral steroids, then we will give hydrocortisone IV injection. Okay, or the doses are here. So number one, as we discussed, oxygen driven nebulizer. Secondly, ipratropium bromide, and thirdly, steroids. But steroids you will give if the child can tolerate orally, does not vomit, is not too breathless, you will give oral. Otherwise, you will give injection hydrocortisone. Okay. Same, you will reassess if meets the discharge criteria. The same is the discharge criteria. Then you will prepare for discharge. Otherwise, if with the reassessment and with the treatment he does not improve, then we will consider admission. Okay. So at this point, you have involved the consultant already, and you will admit. So what to do with the admission? What is the plan for admission? Okay, so you will admit with oxygen. You will admit with the 1 to 4 hourly salbutamol nebulizer, and you will admit with the ipratropium bromide and frequent assessment and oxygen saturation monitoring and vitals monitoring. Okay, so these are this was as for the management of severe asthma. Okay, bye. Mommy. Okay, so this was the management of severe asthma. I will take 2 minutes, then I will come and explain the life-threatening one, the differences to you. Okay. Okay, so this was regarding the mild to moderate asthma. Then the severe asthma, if it improves, we can enter into this cycle, you know, for discharge, meeting discharge criteria, then discharge. But if no improvement, then go towards admission. Now coming towards the life-threatening asthma. So what are the major, who can tell me differentiating features between severe and life-threatening? Because distress is here already, inability to too breathless to talk and too breathless to feed. So what is the most important feature to differentiate between severe and life-threatening?
Cyanosis and decreased effort, silent chest.
Good. So silent chest and
Altered state of consciousness.
yes, altered state of sorry. Good. Okay. So this is the important differentiating feature. So cyanosis or pallor, the child is completely pale, cyanosed. He has a silent chest. There is absolutely here there was distress, but here there is poor respiratory effort. So it's sort of a respiratory failure. Okay. Good. Respiratory decreased conscious, altered consciousness. Saturation is same here, and peak flow we do not rely upon, but this is something that, you know, it comes in the categories as well. But the importance is silent chest, cyanosis, altered conscious, poor respiratory effort. Okay. So what is the first important step in the management of life-threatening asthma, as I pointed out to Nagam as well?
It's inform consultant and PICU.
Yes, important thing is to inform your intensivist team. Okay, inform on-call consultant and PIDS ICU immediately. Then rest of the treatment, if you see the start is the same, you know, oxygen-driven nebulizer, because this is the same for all. And ipratropium bromide, but the difference is between the steroids, because here you will consider oral steroids, but if not taking, then you will go towards hydrocortisone. But in life-threatening, of course, it's no-brainer. It's important that you will start with the hydrocortisone injection. Okay. Then after this, what is the next step if no improvement? Have signs of shock sodium chloride as well. So what is the next step after giving nebulized oxygen, ipratropium bromide, 1 injection of hydrocortisone? So what is the next step?
IV salbutamol.
IV salbutamol, good. Okay, what after that? IV magnesium sulfate, and thirdly, salbutamol infusion. Okay, so just remember in this sequence. Injection salbutamol, continuous nebulizer, by the way. Okay, so injection salbutamol bolus, what we call magnesium sulfate, and salbutamol infusion. This we do not, I mean, very rarely use, but magnesium sulfate and IV salbutamol is more commonly used. Okay, so what is here? Continuous nebulized salbutamol, repeat epratropium bromide. If poor response, give every 20 to 30 minutes. Okay, so every 20 to 30 minutes of salbutamol and epratropium bromide inhalation. Okay, I need to remember the dose and everything. So this was your algorithm for the acute asthma exacerbation. The identifying signs, what you manage, discharge criteria, discharge home medication plan, everything it's in here. So it's a very good slide. So discharge criteria, I've just opened it for you here, but it's the same thing. Saturation should be more than 94. So vitals should fit into this. Peak expiratory flow should be more than 75, and he should be stable on a 4-hourly treatment. This is very important.